Good morning, everyone. Welcome to today's Thyroid by MD's webinar. I am Camilo Gonzalez Velasquez, your host for this session. Thank you for joining us for another recent publication, for a discussion for another recent publication titled Survivorship, Quality of Care of Life, and Transition to Adult Care for Pediatric and Adolescent Thyroid Cancer Survivors. Today, I am pleased to introduce Dr. Aime Franco, Director of the Pediatric Thyroid Cancer Translational Research Laboratory at the Children's Hospital of Philadelphia. Dr. Franco, a thyroid cancer survivor, spearheads research into unique genetic and environmental aspects of pediatric thyroid cancers, focusing on innovative treatments to overcome therapeutic resistance. Her academic journey includes PhD from Vanderbilt and postdoctoral fellowship from Memorial Sloan Kettering Cancer Center in New York, making her a passionate advocate for bridging research and clinical care. Alongside her, Dr. Andrew Bauer, a pediatric endocrinologist and director of the thyroid cancer of the Thyroid Center at the Children's Hospital of Philadelphia. Dr. Bauer's expertise covers a broad spectrum of pediatric thyroid disorders, and he has co-authored over 140 manuscripts and founded the CHOP Advanced Thyroid Cancer Therapeutics Program. He leads the Child and Adolescent Thyroid Consortium and significantly influencing both research and clinical practice worldwide. I want to thank you both for carving out some time to share your work with us. And I'm really looking forward for this presentation, and as I know the rest of the audience is. With no further ado, Dr. Franco, please, the mic's all yours.
Great, thanks so much. And let me get my slides, and hopefully you're seeing the intro, the full slide. So thank you so much for the invitation to talk about this. This is a paper and review and probably somewhat of an opinion piece that Dr. Melanie Goldfarb and I put together. This is a very passionate topic for both of us. For a little different reasons. Melanie actually seeing patients, myself being a survivor, but we really started to put this together, really trying to formulate some of the best practices that we felt should be in place for pediatric and young adult patients that are transitioning to adult care, and going through and really finding where our gaps are in clinical care, but also where the gaps are in our knowledge base, so that we can really do more research and understand this to really set new initiatives forward so that we really have evidence-based care. You know, a lot of what I'll discuss has been based on the models that have been developed for other cancers, both in the adult and in the pediatric space. But there's a lot of challenges to implementation of this in thyroid cancer, which we're going to talk about.
Amy, before we go on, I'm not being able to see your slides. I don't know if Justin, can you see them? There we go. There we go.
Sorry, great, thank you.
We're looking at them right now as a presenter mode, so we can see your notes. I don't know if you want to.
So let's see, new share, and let's.
Beautiful.
Still presenters, you got the right slide now.
We got the right slide. Sorry for the interruption.
No, thank you for letting me know. So my disclosures, I really don't have any financial disclosures, but as was mentioned, I am a thyroid cancer survivor. So I was diagnosed as a young adult. I was 22 in my senior year of college when I was diagnosed with thyroid cancer. So this really has been a very personal journey for me. I really never had any intentions of researching my own disease. When I went to Vanderbilt, I was a cancer biology major, and I actually investigated H. pylori and stomach cancer. It was really kind of serendipitous that I ended up in a thyroid cancer lab and joined Jim Fagan's lab in New York City. But again, there's a little bit of ignorance is bliss, and it becomes a little cloudy when you are investigating your own disease sometimes. But it took a while, and it was quite a journey for me to realize that my voice as a survivor and my lived experience with the disease actually could add so much more to what I was able to do in the laboratory and the questions that we could ask. So I think it's important to disclose that because some of what I'll talk about is really based on my own personal lived experience through this, and understanding really about this transition and what needs to take place for us to best serve our patients, both as patients, but as whole people. So I think what's really important, and one of the things that is the first thing to really talk about in survivorship and cancer and discussing a cancer survivor is definitions, because words are so significant and they matter, and they really often mean different things to different people. And I think the first thing that's really important is to talk about cancer survivor and the term itself, because it was designed by and it was annotated by the National Comprehensive Cancer Network, really and they define survivor as a person with cancer from the time of diagnosis throughout the balance of their life. They also said that survivors will include family members in that immediate support network. Um, the idea was to have a unified definition to bring people together. But I'll say that this term doesn't resonate with many. Like I said, the intention was to have this universal definition and something so that we could all be talking and referring to the same thing at the same time. But this is an extremely contentious definition for many cancer survivors. Those that have metastatic disease, so not thyroid cancer with metastatic disease or even other malignancies with metastatic disease, really don't like the term survivor, as they feel it sometimes connotates this idea of you have to do something, something's been done, this warrior mechanism that for some reason, if you don't do well, that you've done something wrong, where in fact it's actually the disease that is affecting us, not something that we've personally done or haven't done. Some don't resonate with this idea of survivor, as they think that this connotates an after and before and after instead of this entire continuum. And I think for many thyroid cancer patients, we're going to talk about this in a little bit, is this connotation that often is associated with thyroid cancer being the good cancer or a survivable cancer, not, usually associated with mortality, is, are we allowed to use this term? Are we really a cancer patient? I can tell you on my own cancer journey, there's many times with practitioners, not my own thyroid practitioners, but in the periphery of my care, as well as, with family members that, well, you only had thyroid cancer. That's not a real cancer. And a lot of that comes. So this baggage and this terminology, I think, is really important in understanding what this means to the patient, what this means to the physician, what this means to the community members, and trying to make sure we're going off of the same terminology. I will say for myself in the advocacy space, as I've worked with cancer patients, I really wish we could come together across the spectrum of all types of cancers and really become unified on this definition. Not that this is something that defines us as a person or what we do or how we live with this disease, but just so that we can all agree that this is, a label and what the true definition from time of diagnosis through the balance of life, so that we can all be talking with the same thing, and not take offense to using this as a definition and not a label per se. With that, I think then the next aspect is survivorship. And what is survivorship? I think this means many different things to different people. The NCI, and this is a definition I picked just off the internet, from the NCI website, is that they define survivorship as focusing on the health and well-being of a person with cancer from the time of diagnosis until the end of life. And again, it's that entire continuum from the time of diagnosis all the way to the end of life, whether that is from the disease, other aspects of your life, just end of life. So I think this is really important. And again, to use these definitions so that we understand and we're all talking about the same thing and on the same page. I will say, as a cancer survivor, I'd actually never heard this definition of survivorship, and I had never heard of a cancer survivorship plan until 2018. That was 19 years after my initial diagnosis, when I was at a cancer advocacy meeting with cancer advocates from across the spectrum of disease. And I will say I felt robbed, I felt cheated, I was angry that I had absolutely no idea that this even existed, that there was a way and there was a mechanism for me to really think about how my life changed with a cancer diagnosis and really focusing on the well-being of me. So much of survivorship of what I had seen was really focusing on the health. I taking my meds? Are my TSH levels correct? Are my T4 levels correct? You know, are the ultrasounds clear? Is there any evidence of disease? But there really wasn't a focus on me as a person and how this diagnosis had changed my life, my outlook. I was diagnosed at 22. I didn't know what normal looked like. I had no idea what pregnancies would look like, developing relationships as a survivor. All of those aspects, those had never been conversations and discussions. So like I said, this whole idea of survivorship and a survivorship plan was something completely new and foreign to me. And really kind of changed my outlook and revolutionized how I thought about my post-diagnosis life. But again, it was something that had not been discussed and something that I wasn't even aware of in this realm and in this field. So then I think, you know, with that and trying to make sure that we're all off of and talking about the same definitions and just talking about survivorship, what are the goals of survivorship? And I think for most, if not every cancer patient, regardless of where you are on the spectrum of disease, you want to thrive after a diagnosis. Your life is never the same pre and post hearing that word, you have cancer. And it encompasses everything really that's in this wheel of dealing with the long-term symptoms and management, surveillance. That's the real clinical, and that's very disease specific. But the rest of this wheel is all of the other things that are so important and critical to the patient of healthy living and goal setting, mindfulness, finding meaning, you know, nutrition. How do things change pre and post diagnosis? Are there foods that I'm tolerant to, intolerant to? How does that change? How is my physical activity going to change? You know, the thyroid is the central node for all metabolic activity. How is this going to change? What does my new normal look like? And then sexual health, hormones, and body image. And I think this is extremely important. It's a topic that as a young adult was never addressed and never part of my clinical conversations with practitioners. But I think this is extremely important for pediatric young adult that are making these transitions of knowing how to open up that conversation, how to start these conversations. Some aren't going to want to have that conversation, but many at least need an opening on how to start that or whether this is even an issue. What does pregnancy look like? I can tell you, I talk with many young adult pediatric survivors. They come to me to ask about pregnancy because this is a conversation that they've never had with their clinician, or their practitioners often haven't seen many patients that have gone and transitioned from a pediatric to an adult patient and then gone on to pregnancy. I fortunately have had 3 successful pregnancies after a diagnosis. And even though I can't talk about everything and offer clinical advice, at least it's that support network, and being able to discuss these things and open up those conversations, because many don't know how to open those conversations. And I think what becomes really important, kind of back on that first slide, is survivorship. The big component is that long-term system management and surveillance, the green box. But for us as patients, the rest of the wheel is just as important, if not more important. But a lot of times the clinical goals and the individual patient goals may not always align. And I actually did some more looking, even just putting this together to find out what additional research and publications have come out about this transition and survivorship and what does it look like for pediatric and young adult patients. And the papers that I kept pulling up, the only thing they talked about in the context of survivorship was the symptom management and surveillance. It talked about, you know, whether we repeat RAI, how many body scans, how long do we surveil, what are the medications, how do we, you know, what TSH ranges. There was absolutely no mention in any of these articles about the rest of the wheel. And I think this is something that's really important and where, again, we have to open up these conversations and to understand, are our clinical goals and the patient goals aligned? And how do we put those into alignment? And as clinicians that are practicing, perhaps this is completely out of the wheelhouse of expertise, and that's okay. This doesn't mean that each of you have to always be able to address each of these, but ways to open up those conversations, to have referrals, to refer to a nutritionist. It wasn't until 20 years after my diagnosis that I got a referral to a nutritionist. And that was huge for me. We couldn't address it in the clinic with some of the weight gain issues I was having. We didn't know whether it was due to my nutritional needs and due to medication, but just opening up that door and giving that referral was enormous. And I will say that took 19 years for me to get. And I'm an expert, even though I'm not a clinician in this space, I'm an expert in this field, and it was still something that I wasn't aware of. And I really feel for those patients that are not like me, that don't live this every day, both professionally as well as personally, that don't understand all of this, and you don't know what you don't know, that if we don't open up those opportunities and open up these doors and provide awareness, that many of the patients really don't even know what they're missing or how they could improve and have improvement in some of these other realms. So talking about specifically, I mean, I think that spectrum is what survivorship is in the realm of survivorship, as not necessarily even specific to thyroid cancer itself. But there are some unique and individualized goals and aspects of survivorship specific to thyroid cancer. As I had mentioned, I'd never even heard of survivorship or a survivorship plan until I was in a cancer meeting that had nothing to do with thyroid cancer. And I was actually the only thyroid cancer survivor in the room. It was people from all other cancers that knew about this. There's tons of resources that are available, and there's a lot of survivorship plans that are online. But in thyroid cancer, the implementation is really low. And I think a lot of this is because we're most often treated in endocrinology and not oncology. We have to figure out ways to bridge this gap. And I hope Andy's going to talk a little bit about this, especially with the development here of the clinic he's instituted, bridging oncology and endocrinology. But I think it's opened up doors not only for in the therapeutic space, but also the opportunities and these best practices that exist in oncology. There's been so much done in the pediatric oncology space of support for pediatric cancer patients and care plans and support networks. But those of us in the thyroid cancer space that aren't treated in those oncology spaces never hear about them and don't know about them. And you don't know what you don't know. And I think in all fairness, in the clinical space as well, you're not working in oncology clinics all the time. Many of our practitioners are not working side by side in the confines of a cancer center. So they aren't even aware. And it's not by maleficence by any means, but I think having these types of conversations, bridging this gap and understanding and really bringing the resources that are available, specifically the psychosocial resources that are available in oncology, and how we can implement those in endocrinology and for our patients will be extremely beneficial. And I think another big challenge is the stigma that's associated with the good cancer. You know, I know this has been a debate for many years, and we've talked about it, and I think it's gotten better. But I will say, you know, when I was diagnosed, the very first thing that my physician said, and I was diagnosed by my primary care physician, was, well, I'm so glad it's thyroid cancer, because if I was going to get cancer, this is the kind of cancer I'd want. And it's those conversations that are extremely well-meaning, but they also shut down the opportunities many times for asking questions. I was 22, 23 when I was diagnosed. And by starting the conversation of, I'm so glad this is the kind of cancer you got. If I was going to get cancer, this is what I want. It shut down for me the ability to ask further questions. So I think we have to think about how we present our information and the conversations we have, and the words matter to make sure that we open up doors and not shut doors. I think it's all unintentional doors that are being shut. And of course, using something and talking about the good cancer is absolutely trying to convey that this cancer more than likely is not going to kill you. But by talking about it in the good cancer, we forget about all of the morbidities that are associated with this. And the fact that, you know, despite the fact that thyroid cancer isn't going to kill me, since I was 23 years old in January of 2000, I have not had a thyroid. Every single day since then, I am dependent upon taking a pill to supplement and provide that thyroid hormone. Yeah, I can miss days, right? I know it's not going to kill me, and I know all of that information, but my body cheated me and failed me, and I am now dependent for the rest of my life on taking a medication. That completely changes my outlook, the way things look, and those aspects of how life-changing and how my daily behaviors have to adjust because of this, um, feel at times like they're diminished by being labeled with this good cancer or something that's not going to kill me. So I think, it's just to emphasize that really words matter and thinking about what conversations we may be preventing or not facilitating when we use certain words in certain situations. So kind of moving a little bit into what is a survivorship plan, the goal really is to address supportive care and practical needs. And again, I think we need to expand this definition and make sure we're not only addressing the clinical needs of surveillance, the need for surveillance or not to surveil, looking at TSH levels, what do our different hormonal levels look like, measuring TG, do we need ultrasounds, do we not? And to identify about some of those late effects of cancer treatment potentially. Um, how do we identify and monitor for the secondary cancer or recurrence if that occurs? Um, Especially in the pediatric and in the young adult, the transition of care, which we're going to talk a little bit more about in a second. But then also to address the practical needs, those psychosocial needs, how those are going to evolve as you transition from a pediatric, a young adult, adolescent patient into adulthood. How do those psychosocial needs change? When we're talking about a pediatric patient, all of those, or probably the vast majority of those, are going to be taking place with, you have two patients. You have the parents and you have the the actual pediatric patient. As we transition into adulthood, now these patients are forced to manage their own care. So we're not only talking about transitioning out of a pediatric space into an adult space and the different needs of a pediatric versus an adult patient, but we're now also talking about the different psychosocial needs of transitioning from mom and dad are in charge of my care, or in every single one of my visits, they're helping make those decisions, to transitioning to making your own decisions. For some, this goes really smoothly. For others, they don't even remember what their treatments were. So having all of that documented is extremely important. Another aspect of it that has come about that honestly I'd never even thought about until now my own children are turning 18 is the legalities of what can and can't be shared with the patient and gaining, or with the parents, excuse me, and gaining the the consent from the patient. And no longer is the patient consenting with their parents, but they're consenting for themselves. Those are big steps. Some are going to be ready for it, some aren't, but these are all of the things that we need to keep in mind. And when to implement the survivorship plan. These conversations need to start well before the transition begins. And the awareness of what all of those needs are, both in the clinical and in the psychosocial, and then also thinking about how that transition looks when we're transitioning potentially not only from a pediatric to an adult space, but changing from a chaperoned condition, so to speak, where parents are probably very intimately and ingrained in those decisions, to an adult space where perhaps they aren't going to be quite as ingrained or as quite a part of that. And remember, in the oncology space, I think we're very used to having patient partners come in part of that decision making continuum and part of that decision making. That's not always the same practice when you are in endocrine, or even when you're in uh, general care and with primary care, excuse me, primary care physicians. So the way that these conversations and the decision making takes place often is very different between the pediatric and the adult space. So not only are we talking about just disease management and thinking about those, we're also talking about a completely different way in which care and the actual visits are managed. So I think that's something to keep in mind with patients. This is also a concept, and I just put it up there, palliative care, because I think we conflate palliative care with hospice care. And palliative care was something that I'd never even known of, but again, with survivorship planning and survivorship care, all of a sudden I became aware of this term palliative care and that it has nothing to do with hospice or end of life, but it really is that entire being. And I think this is something that is completely underutilized in the thyroid cancer space, and a conversation that should be had to demystify that palliative care does not mean end of life care. It does not mean hospice, but how different palliative care physicians and practitioners can be involved and help to address a lot of the psychosocial needs that very well could be out of the realm of what is in the normal clinical practice that takes place. So just to really briefly summarize, a survivorship care plan and what needs to be in this at the bare bones is a summary of the treatment. Remembering that this patient is transitioning out of your clinic. They were treated as a young patient. They may not even remember all of the therapies that they went through. Electronic medical records sometimes talk nicely, sometimes don't. So really trying to take the burden off of the patient of remembering everything is to having this in a concise summary. Identifying those long-term goals and risks, and that's both clinical goals as far as, management of the disease, but also those psychosocial goals and where that plays a role. How to assess care, how to address these needs, and then finally that transition of care and whether that's into an adult endocrine clinic. Is this going to be into an adult primary care clinic? I'm hoping Andy's going to talk about this, but we can also talk about it in the discussion is that pediatric thyroid cancer looks different than adult thyroid cancer. So the transition and the features of a pediatric disease into an adult clinic are different. We see many pediatric patients that will have persistent pulmonary metastasis that isn't under active treatment. We're not treating them with radioactive iodine. Those nodules are sitting there as persistent disease, but they're not progressing. But getting into an adult clinic, that is pretty jolting and pretty triggering for many adult endocrinologists that don't see that in the normal practice, because the adult patients don't usually present with persistent lung metastasis that doesn't actually progress. So the last aspect is quality of life. And, again, I think definitions matter here, and it's so critical to think about this. The WHO and the World Health Organization defines quality of life as ones. And I emphasize this, bold it, I can't emphasize it enough. This is an individual perception of their perception in life in relation to their goals and value system. Whereas there's the health-related quality of life, which refers to the patient's physical, mental, and social well-being and ability to perform daily tasks. They're related, but they're not the same. And very often we conflate these terms and we're using them interchangeably. And also the quality of life it's a very personal thing. So we have to take into account an individual's perception and an individual's journey. And thyroid cancer survivors, young adult as well as adult, often have been found in these series of questionnaires to have quality of life as well as health-related quality of life that's comparable to survivors of cancers with a much higher mortality. Which again goes back to this idea of labels and the good cancer, and this idea of survivor's guilt and the guilt associated with feeling like you have a lower quality of life, lower quality health quality of life, having these concerns, even knowing this disease isn't going to kill you, because there are a lot of morbidities that are associated with the disease. And unfortunately, we lack the data for pediatric and adolescent specifically in a lot of these metrics, and we are almost completely lacking in the long-term data in this population. And again, much of this is lost because we transition from a pediatric setting to an adult setting. But again, it's not within a cancer center. So there isn't necessarily the longevity and the full tracking of the entire continuum within a unified health system. And understanding that thyroid cancer survivors in that young adult and pediatric population, many of them are going to be mobile. They may not reside and spend the rest of their life where they were diagnosed. I was diagnosed as a kid in Connecticut. I have moved 5 times since then and have medical records across the spectrum. So trying to keep that all in one place, especially when you're dealing with young adult survivors that can be very mobile, is really important to have. And these are the factors that impact quality of life. And I want to try to wrap up to make sure I give Andy as much time as possible. But this was specific to thyroid cancer. But the fear impacts quality of life, despite the fact that the disease may not kill us. There is the constant fear of recurrence. And this idea of that you don't fit in because we're not really a real cancer survivor, or we have the good cancer, and where do we fit on that continuum? Really, many of us are unprepared for the reality of post-diagnosis. And again, this comes to discussion of clinical needs, but not those psychosocial needs. And really, this idea that thyroid cancer becomes a chronic disease because those that are treated with a complete thyroidectomy are dependent upon thyroid hormone supplementation and daily medication for the rest of their life. This is not a finite endpoint. This is something that goes on forever. And I think we don't often talk about the chronicity of this disease for those that are going to transition. There is that, again, survivor's guilt that's associated with the labels of the good cancer, the fact that we had cancer, but it didn't kill us. And really, how do we reconcile different factors at times? And I'll say this doesn't affect everyone, right? This is probably significant for 30 to 50% of patients, which means there is a big chunk that don't think about this on a regular basis. But we have to use inclusive language and ways in which we can open up the opportunity and give the space for those that have these factors that are impacting their quality of life, to find ways and mechanisms to improve that quality. And I brought this because I think I saw this on Twitter the other day, and I think this is really important. And this is something, again, that really resonated with me. And it's actually been talking with other cancer survivors, not thyroid cancer survivors per se, but this feeling that you're not safe in your own body. And you're always wondering if you're sick again, or, my body tried to attack me with my thyroid. What's next? And really, that PTSD and that psychosocial aspect of it is real. And we need to be able to have these conversations and address that. There aren't necessarily answers to it, but it is absolutely a real thing. I'm not going to spend a lot of time, but I think it's really important. And I know Melanie has spent a lot of time looking at this specifically, is the financial toxicity that's associated with all cancer diagnoses, but especially with thyroid cancer. It hasn't been researched and looked into much in the pediatric and the adolescent population, but this is a significant concern for adult thyroid cancer patients. And again, it goes to the chronicity of this disease and the fact that it follows us for the rest of our lives. So I know these slides will be available. I'm not going to go through all of this. I think this is a good resource, but I think we can't solve this. This isn't something to solve in the clinic, but I think it's something that we have to be aware of and think about for our patients. And understand that the financial strain and the financial stress is real. When you're on Synthroid and it's branded and it's a drug that's not covered in some of the pharmacy formularies, then you're paying 3 times the price if you were on the generic. These are significant financial concerns, and something that is going to be in the back of the mind of patients. And it's extremely concerning at times, as for those patients that make that transition, that are really trying to transition to financial independence, but now are associated with all of these costs that are long-term, that are come because of their disease. So up to 60% of pediatric cancer survivors who transition to adult services experience disease-related complications. This is direct from the paper, and this is really pan-cancer. This is not thyroid specific. But some of these challenges that occur is because, we don't have a universal definition of when does adulthood begin. 18 is adulthood in a legal space. This is when I talked about, HIPAA violations and how do we transition and talk to patients, and those become legal concerns. But within the medical field, we really don't have a full definition, because it's not, a cut and dry, and every patient is different. So, but this just adds to the complication of how we transition care. How long is it reasonable to stay in a pediatric clinic? You love your pediatric clinician, but at 26, when you're walking into a waiting room and everyone is, 10 and 12, what other issues become problems? And I think we need to help initiate, or another issue is who should initiate and lead that transition. And I think, again, those conversations need to happen early, and it is going to be very patient specific. But those there has to be space to have those conversations. And how do we continue the continuity of care and information? I think, this is my soapbox, but I think we need policy change as well as practice change, because again, these definitions aren't universal. The transition from pediatric to adult outside of thyroid cancer is messy. When do you leave your pediatrician and go to a family practitioner or get a new primary care? We don't have policy on how to do this in the healthy state, and it's no wonder it's kind of a mess in the disease state. So I really think it's critical for us to have the policy change as well as this practice change. And finally, this is going to be a selfless ploy and plug for the Child and Adolescent Thyroid Consortium. So Andy may talk about it as well, but the CAT-C was formed here at CHOP under the auspices of Andy and Amber Azaza here, really with the goal of revolutionizing how we treat thyroid cancer, so that we have more data to drive evidence-based practice moving forward. So we have both a data repository as well as a biorepository that I manage, so that we can, really increase our investigation, because at the end of the day, pediatric thyroid cancer is still a rare cancer. And I think having these conversations is so critical, because not all of our pediatric thyroid cancer patients, as well as our adult thyroid cancer patients, are treated in centers of excellence. So we really need to have the evidence and data so that we can share and develop best practices, and then continue to have conversations and forums like this where we can share this information across institutions. And really, this is what we've tried to do with the CAT-C, is really develop these partnerships and develop a worldwide pediatric thyroid community that supports the clinical trials, but improves the focused on improving care, and also ways in which we can standardize these transitions and share best practices, and work together to create this better world for our patients, and a smoother transition. So with that, that's what I have. I'm going to turn it over to Andy. Sorry, I went longer than I was expecting. And then hopefully we can open up to questions.
Thank you, Aime, for a very interesting presentation. While Dr. Bauer pulls up his slides, definitely an eye-opener for concepts of thyroid cancer care that we don't think about as often, or that we don't have at least as clear in our head as the regular clinical goals, as you mentioned before in your presentation. So thank you for that presentation. I'm gonna let Dr. Bauer take it on, and we'll come back for the Q&A and discussion.
Well, thank you, Aime, and also for the invitation to talk about an important topic. It's always informative to hear from someone who understands the biology of thyroid cancer, but also lives with the disease. And I'm not going to be able to answer all the questions and all the shortfalls in care that we currently have in trying to address health-related quality of life and transition of care in pediatric patients. But hopefully bring to light that there are opportunities for all of us to work together. And there are some tools that are available. Some are in our system, but some of them are actually available across systems. One in particular that I'll bring up at the end. So these are my disclosures. None of these will impact what we're talking about today. But as Aime mentioned, there's multiple studies in adults looking at thyroid cancer. And again, it's not the prognosis that impacts quality of life. It's just the process of having a cancer and undergoing the treatment, and the implications of the word cancer that impact quality of life. And so adult thyroid cancer patients have many similar things to other cancer survivors. And I think sometimes even compounded, because this is a disease that patience is an important part of treatment. And we have patients that continue to have evidence of disease that we're not addressing. We don't use the word remission, but we're not actually giving additional care. We're just following these patients. And understanding what it means to have a chronic cancer is another part of quality of life, and really an important part, as Aime mentioned, for transition of care. In particular, patients with pulmonary metastasis that eventually transition over to adults that we've been following for years without additional treatment. And when you throw all these things into the pediatric world, of course, how the diagnosis, treatment, surveillance impacts the person is compounded by the person who's developing. So the person is developing prepubertal and then pubertal. And then right at the time that we're transitioning them, they're trying to figure out who they are and to make it across the obstacles of becoming independent, and having a cancer diagnosis that if they achieved remission, worrying about recurrence and relapse. And if they haven't achieved remission, what does that mean as they start to enter into the adult community? And does their adult provider understand or not understand the pediatric presentation of thyroid cancer? So it really is an opportunity where we need to be better about communicating across adult and pediatrics and helping our patients make that transition. If we come together, it makes it easier for them. So you go to PubMed and try to figure out, well, how many articles are out there to help address this and who has been investigating this. And you realize that there's a huge list of compounding factors that impact quality of life. And there's a huge number of survey instruments, some of them validated, some of them not. And so this is an article that's now 13 years old, but it makes it even harder to understand what our patients are going through if we don't start to standardize what we're looking for and to create prospective studies, that we have partnerships between pediatrics and adult providers helping to care for these patients. And so quality of life, if you do, these are search terms, you can see, wow, this looks awesome. We're going to have a ton of articles to go through, probably too many than you can actually go through. But then when you start to add additional search terms, you realize that the number of articles begins to dwindle until the bottom of the screen, which is the article we're talking about today. So there's not a lot of data out there, which is frustrating, but it's an opportunity. So it depends on how you look at your glass of water. And so if you put in transition, there are a number of articles again. But interestingly, of course, the one we're talking about is one of the three. And two of the three, Melanie Goldfarb, who's an endocrine surgeon in California, has been involved in writing. So again, just to highlight that this is an area of need as far as addressing this patient population, and there's lots of opportunities to improve what we're doing. If you look at transition of care rather than just quality of life, there are lessons to be learned from other transition care programs. So transition of pediatric to adult for cancer, there's 475 articles. And endocrinology or endocrine, it depends which search term you use, there's somewhere between 300 and 350 articles. So it's not for a lack of a template that we could follow. It's a lack of putting the effort in to actually create this transition plan and to follow quality of life for pediatric thyroid cancer survivors. What we've learned from what is out there is that knowledge of the disease is key to helping a person have a more positive outlook and to be more actively engaged in their healthcare. And the education really has to focus on the disease itself, what the treatments are, what the outcomes, what the goals of treatment are, what the potential complications are, both acute, subacute, and chronic, and what the prognosis is. And to say 98% of our patients survive is awesome, and it's true. And the most a pediatric patient, even with pulmonary Mets, can be as far as AGCC TNM is stage 2, all the way up until age 55. But that somewhat reassures us as providers, and if it depends on how it's sold to the patient, may minimize what the impact of the diagnosis is on the patient. So you still have to inform them beyond this is a survivable cancer, to educate them what the potential complications are in the short term, long term, and what their anticipatory guidance is as far as their surveillance over their lifetime. I'm not going to go into all the differences of pediatric versus adult thyroid cancer because we want to have some time for discussion. But just thyroid cancer in general is for all of us, adult and pediatrics, presents much differently than many other cancers. And I think one of the most difficult things we hear from our patients, and back to Amy's point about PTSD, is you take an otherwise asymptomatic patient and you find out that they have a nodule and the nodule is cancer, and then you biopsy it and they have surgery and radioactive iodine. And it's blindsiding if you talk to the patients that they otherwise felt A-OK, asymptomatic, and they're now going through this and they have a diagnosis of cancer that needs lifelong surveillance. So there's many aspects of thyroid cancer which all of us are involved in helping to care for that are a little bit different than other cancers. And so there are things that we have to be more cognizant of as we develop these plans. So the goal of studying quality of life in transition is to identify patient and family specific factors associated with lower quality of life, some that we can address individually and some we just have to try to address as a cohort of patients. Identify opportunities to direct support services early. So we use a stress thermometer as part of our clinic. We've been doing that for 12 years. It takes about 15 seconds for someone to look at the stress thermometer and to identify where they are on that thermometer. And in real time, that allows you then an opportunity to talk to whether it's social work services or ONC behavioral health or both, and bring that person into the clinic visit. That may not take you more time as an endocrinologist or oncologist, whoever's caring for the patient, but does provide a service to the family rather than one, not addressing it, and two, trying to make a second appointment. Many of these services are available in our hospitals. We just have to create systems to bring them into clinic in real time for patients that are really undergoing stressful situations, whether it's socially, socioeconomically, or medically, or both. And then try to identify things that increase resilience. And there's a huge list of books and topics, and there's a program at our hospital, and many pediatric hospitals have programs to help identify factors of resilience, but involving patients in their care, informing them, irrespective of age, asking them how they're doing, and teaching them about their diagnosis are factors that improve resilience. So the last, to close right before the discussion, hopefully about 10 minutes to open up for discussion, is things that we've learned in our center. So the first article we wrote on this, and we don't have a long list of articles, was now 12 years ago. And it was a response to an article that was written about 16 pediatric patients, 11 of the 16 in remission, and brought up the fact that there was no significant differences in anxiety or quality of life between PEDS patients and their comparative group, which was Hashimoto patients. And that focusing on the positive aspects of life may outweigh potential negative impacts of being diagnosed and treated for thyroid cancer. And we were a little taken back, and try not to be overcritical, but just raise awareness that, this is a small study, and the final conclusion of the study is we need to do more studies. And that was really the focus of our editorial. Like, this is a sub cohort of patients that really has done excellent. And it's hard to draw any type of conclusions for just 16 patients. So from that experience, we started to follow health-related quality of life. We use a validated survey in our clinic. We use the stress thermometer, as I already mentioned, and we have longitudinal assessment of our patients. We've tried 6, 12, 18, 24 months. One of the challenges in pediatrics, which is a good challenge, is we have less contact hours. Patients may come in every 3 months, and now most of them come in every 6 months, even after their initial diagnosis. And so there's less windows of opportunities to bring these types of survey instruments in. We initially had paper, and now we have either web-based or an iPad that we can use in clinic. But some of the challenges are like, how many pages of a survey are you going to actually have a patient fill out? The parent survey is 2 times as long as the patient survey, but both of them are important. So again, it's a great idea. You want to bring it into practice, but it does take some effort, and it does take some coordination as far as patient flow and turnover in the clinical situation to do this. And it turns out if you have them try to fill this out at home, the likelihood that they complete this task is obviously lower. So the best time to do it is when they're in clinic. We published the initial response to this, and we had way more than 92 patients. But as far as completed surveys with longitudinal data, that's the challenge. Again, that's what the data was. And this is the first author was a postdoc in oncology behavioral health, and the senior author is the head of our oncology behavioral health at CHOP, not just thyroid, but overall our oncology program. And again, similar to adult studies, we see lower health-related quality of life in physical, emotional, social, and school domains. And so our patients really do have these things, and really we need to address them, ask them, and educate them, and provide services. To wrap up the last couple slides, one of the really great things, which I need to be personally better at doing, because it's hard for us sometimes to let go of our patients, is transition. And each of our hospitals, again, probably have now electronic transitions. And the one at Penn is just remarkable. If I put in a referral today in clinic and fill out the form that you see there, within 48 hours, the patient's contacted, and I get an email that say, we contacted the patient, they're seeing this provider, and here's the date. And if they don't reach them, they still contact me and say, we've had difficulty reaching your patient. So I'm surprised it works this well. It's worked this well since I've started using it, and that's well over 2 years now. I just need to be better about using it. But each of our hospitals with the EHR probably has similar things, and this is a web-based way to have physician referral rather than just saying, good luck. And if they're not going to be followed in Penn, then I try to find out where they are and recommend places that I would send my own family members to. And those types of help and transition are really, I think, important and don't take a lot of time out of a clinic visit. And then to close, to Amy's point, the survivor care plan we just started implementing. So Goli Mustafi Moab is the PI for this research project. She's dual board certified in endocrinology and oncology. So this is an area of focus for her. We just launched this, last month. It's a 2-year grant. We're using quality of life. We have a survivor care plan that's put in place. It came from the adults living with after childhood cancer, the ALAC, the Smart ALAC program, which is web-based. It's available. If you list and you look and see how many hospitals are involved, many hospitals across our country have access to this program, which prior to looking at this, I was unaware of. But there are ways to build survivor care plans, web-based, and all you have to do is build the back end as far as the education piece, include anticipatory guidance about, what do we do initially post-op, what do we do long-term surveillance based on dynamic risk stratification, obviously simplified into patient terms, long-term complications, and then just education about the disease. And then it's a digital-based thing. You can incorporate texts to help remind people about patients. And so we're just we've just launched this. We're collecting data and recruiting patients. And to Amy's point, as we move forward, we hope to launch this through our Child and Adolescent Thyroid Consortium. So with that, I will end and just plug to the adults that are listening and involved in Journal Club today. It would also be really helpful for us as a pediatric community if you have childhood survivors in your clinic and they have disease that's advanced that was not advancing during pediatrics. That type of data would be infinitely helpful for us as far as understanding if and when and how and what the percentage of patients that actually progress. And again, as a community, this is the data we can't get in pediatrics, but we can get if we work together as a thyroid cancer community involving both pediatrics and adults.
Thank you both for very interesting presentations and wonderful work that goes behind that presentation. I want to thank you both for opening our eyes to a lot of concepts that we don't usually think about in the clinic day by day. I'm going to first start with a question from the audience. Dr. Pinner Smith is asking, and I'm going to read this so I don't take it out of context. It says, our 2015 adult ATA thyroid cancer guidelines state that the disease-specific death rates are less than 11% with local regional meds and less than 50% with structural meds. When we inherit pediatric thyroid cancer patients with these meds, how do these percentages change? I don't know if
that's exactly my last point. We don't know.
Yeah.
So those are in our data, pediatric data, whether you have pulmonary metastasis or not, the survival rate is somewhere around 95+%. So of the patients in pediatrics that don't survive disease, the patients with M1 disease with pulmonary metastasis are the ones, and it's probably somewhere between 3 and 5%. We don't know whether it's the disease that's causing the respiratory failure or if it's the radioactive iodine treating the disease that's causing respiratory failure, but it's associated with pulmonary fibrosis, advancing pulmonary fibrosis, cardiorespiratory failure. And that's why, we're really thoughtful about using it, but we don't know for the ones that survive, which is 95+%, and of the ones with pulmonary metastasis, which is about it's 30%, 20 to 30% of patients with lateral neck disease in pediatrics. So let's say it's about 10%. to 15% of our patients that have M1 disease, 95% of them are surviving and going into the adult clinics. That cohort of patients, we don't know their outcome. And that's where we need adults to provide that data, adult thyroid providers.
I wanted to ask you, and take the advantage since I have you both here. How do you do that transition? If you're gonna transition a patient into the adult care scenario, what is the bare minimum amount of data? What do you need? Do you have like a format? How do you do it? How do you transfer that patient into adult care?
It's a discussion, and then it depends on where they're getting care. So with the electronic health record, we use Epic in our system. It's the biggest electronic health record software, I think, in the United States, and there's now care everywhere. And so if the patient's transitioning to another facility that has care everywhere, they can see all of the data, their adult provider. And so they may not be able to see all the images, but they can see all the notes, all the lab data, all the radiology reports, all the pathology reports. If they transition to a different hospital, then there are, you have to go through patient administration to get transfer of information. Is that the question, or do you have a different question?
Yeah, that's for one. And the
logistics.
The second question would be, Aime was mentioning people are mobile. What if they transition to another place? We speak about pediatric thyroid cancer and adult thyroid cancer as two different paths, two different diseases, if you allow me. And so what are the things that are different from the pediatric thyroid cancer to adult thyroid cancer that you need to let the adult practitioners know? What is like the things that I'm not speaking only about TG levels, and I'm not speaking about images, but Aime gave us a wonderful lecture about the quality of life and the psychosocial baggage that might carry. How do you transfer that, or how do you communicate that to their next practitioner or health provider?
You want to know the quality of life part or the medical part, or both?
It's up to you.
Aime, do you want to weigh
Well,
in?
I mean, I obviously am not transitioning the patients, but in my experience, there is none, right? Like there isn't the communication about that. And I mean, I was looking because you were asking about, Camilo, about the transition. I actually carry around a manila folder with me with all of my medical records because related to my diagnosis that goes back, because I mean, mine is a 20-year version. But, I think this is something we need to think about, is these patients are going to live and have an entire life ahead of them. Electronic medical records make it a little easier now as far as keeping that in place. But as you move, that's something that was a discussion that was never had, and how important that will be. And again, I don't think we don't need to be reinventing the wheel. It's just providing that education. And as Andy said, I mean, I love the idea of the barometer, right? It doesn't mean in the clinic as an endocrinologist, you need to address these issues, but to say, okay, this is a problem. We have a social worker. Let's bring them in. Let's have this. I can't address it, but I know that this may be in the spectrum of what needs to be addressed. And I think that is the key. And I don't know whether, I guess in many respects, this conversation is one, the pediatricians need to understand that the transition has to happen to the adults, but this is also a conversation we need to be having in the adult community and with adult practitioners to understand a patient diagnosed at 45, 60 as a thyroid cancer survivor is very different on the psychosocial spectrum than that patient that you're getting transitioned through the electronic medical records Andy just showed, that is now 22, that was diagnosed and is already a 10-year survivor. But the questions that they're going to have about, is this going to impact my pregnancy, is very different conversation than you're having with your 45-year-old or even your 30-year-old thyroid cancer survivor. The ideas of, when you have a scan, how long do you wait until pregnancy? Are you actively being scanned as a 10-year pediatric survivor that's transitioned into an adult clinic versus a survivor diagnosed as a young adult that's 25, 30, and how those testing and how, you know, the surveillance changes in those, and then how does that impact your pregnancies, relationships, and things like that. I'm not sure if that necessarily, I think part of this idea of having a survivorship plan to at least know and be able to open those conversations are what I think, for me, I feel is most important.
Totally. I think I wish I had another hour with you guys to just keep on asking questions, but I think what I will take home from today is, one, words matter, and I think I think it's a huge eye opener. Words matter, and the words we use with different people throughout their life definitely change. The idea of having people be mobile more so now than ever makes the multicultural picture a challenge. There's language barriers, there's geographical barriers, and there's many things that we need to change. And from Andy, I'm gonna take collaboration is what we need. So I think closing those gaps between the pediatric world and the adult healthcare system, and the transition in whatever point in life a patient might be geographically or chronologically from the age standpoint, is gonna change the game as the way we will treat patients moving forward. So thank you both for being here with us. This is, as I said, I hope I had another hour. I want to invite you all to be here back with us next week. We will have a presentation by Dr. Gonzalo Acosta about the overuse of thyroid ultrasound. And I can thank you enough. Please stay safe, have a wonderful weekend, and talk to you soon.